Good morning, everybody. We'll talk about coronary artery disease, continue our talk on coronary artery disease, and today we'll talk about acute coronary syndrome, which includes unstable angina and myocardial infarction. If you remember, the previous talk was on chronic stable angina. Just to remind you, coronary artery disease can present in the following ways. It can be asymptomatic completely, or it can present with sudden death. In between these two extreme presentations, you have chronic stable angina, which already we talked last week, and acute coronary syndrome, which include acute myocardial infarction and unstable angina, or the patient right away might present with complications like arrhythmias or heart failure. Sorry, again, to remind you what happens regarding the artery and the muscle. If you have complete occlusion of the artery by a thrombus, then the muscle will get necrosed or infarct. The whole thickness of the muscle will be necrosed. This is called transmural infarction, and the electricity will be directed outward, so you'll have ST elevation. Again, if you have complete occlusion of an artery, which is, say, not a major one, or occlusion of the major with collateral circulation, then you will have an infarction of the vulnerable area of the myocardium, and that is the subendocardial area. This is called partial thickness myocardial infarction, and the electricity will be directed inwards, and you will have ST depression. The third possibility, you have critical narrowing of the artery, but the muscle did not have any infarct, would only be ischemic. This will cause ST depression. So clinically, acute coronary syndrome might be either unstable angina, non-transmural, partial thickness, or non-Q myocardial infarction, or transmural myocardial infarction. But ECG-wise, it is either ST elevation, which indicates transmural, or ST depression. A patient with acute coronary syndrome, you expect clinically present with chest pain, prolonged, etc. When you do an ECG, you might find either ST elevation or ST depression. If ST elevation, this is transmural infarct. If ST depression, there are two possibilities, either subendocardial infarct or unstable angina, and we differentiate these two by cardiac markers. This is part 1 of the lecture of acute coronary syndrome. We'll talk about definition, pathogenesis, clinical features and complications, and part 2 will be on investigations and management. Regarding acute coronary syndrome, I will concentrate mainly on acute myocardial infarction, because by this time you know everything about unstable angina. It's a new onset angina, or rapidly progressing or worsening angina crescendo, or angina on minimal exertion or even at rest. It is somewhat prolonged and frequent, and even the patient tells you that the pain is not responding to rest or sublingual nitrate. But the other part we talk about is acute myocardial infarction, where there is evidence of myocardial necrosis. There is rise of intracellular enzymes and troponins in the setting of chest pain. Acute coronary syndrome can be a new phenomena all of a sudden, or the patient already is having chronic stable angina, and on the top he develops acute coronary syndrome. Regarding diagnosis, we have a triad of symptoms, ECG changes, and cardiac biomarkers. The symptoms, central severe chest pain radiating to the arm. So either two of the three is enough to diagnose infarction. Symptom plus ECG, symptom plus markers, and marker plus ECG, but the cornerstone actually is the cardiac markers, which indicate necrosis. So diagnosis of acute MI, rise and sometimes occasionally fall from normal of cardiac biomarkers plus symptom of ischemia, new ECG changes, ST segment elevation, or new left bundle branch block. For example, on admission he has a normal ECG, but after half an hour he develops new bundle, or development of pathological Q. Imaging also help, for example, echo or other image technique, and identification of thrombus by angio. These are out of your scope. It's enough for you to know that cardiac biomarkers plus symptom or ECG change. Now, what is the pathogenesis of acute MI? As you know, the main pathologic process is atherosclerosis, which has a plaque. The culprit plaque, the plaque that is responsible for the lesion, is a complex one, not a simple one, usually ulcerated or fissured. An ulcerated or fissured plaque will get a thrombus, which is platelet rich on it, and probably it will also have some local spasm. So it will increase in size to completely occlude the vessel, but occasionally it will regress. Complete occlusion of the vessel might end in spontaneous lysis or permanent occlusion. Anyway, when you have complete occlusion of the artery, the muscle will suffer loss of blood supply. So you will have necrosis by the first hour of subendocardial area. By 4 hours you have more, and by 8 hours you have a transmural infarct. But just have a look on this color. You have a normal myocardium, you have a necrosed myocardium, and in between this orange area is ischemic zone. I'll talk about later on this. This is neither dead nor completely normal. It is ischemic or oligemic zone with decreased metabolism. Now, how the patient presents clinically, obviously all of you know. The commonest presentation actually is chest pain, which is the same site of angina, central, but is more severe and lasts longer. Probably associated with breathlessness, anxiety, and even fear of death, scared of death. The second presentation is collapse, all of a sudden, due to arrhythmias or profound hypotension. Anybody with collapse, be careful. It might be associated with parasympathetic stimulation. And sudden death again is another presentation. And lastly, due to arrhythmias. And lastly, cardiac failure or heart failure related to the extent of the infarct. Now, what physical signs of the patient? In cardiology, always remember general, and then go to the pulse, blood pressure, JVP, and precordium. Generally, the patient will look pale and sweating. This is because of sympathetic activation. So, if you have a patient with central chest pain who's pale and sweaty, be careful. It's not like the same with left-sided chest pain, a young patient who looks normal. This might be associated also with parasympathetic stimulation, that is vomiting and bradycardia. Also, the hands might be cold due to decreased tissue perfusion and oliguria, decreased urine output. Sometimes there is a rise of temperature because of tissue damage. The pulse, either normal or narrow pulse pressure, rather weak. Blood pressure might be normal or the patient might be hypotensive. JVP might be raised. Precordial examination, the apex might be normal place or displaced. First heart sound might be normal or quiet, and there might be a third heart sound, an indication of left ventricular dysfunction. In addition, you might find cryptation on the base of the lung, which indicates that there is left ventricular failure or heart failure. Of course, differential diagnosis of chest pain, cardiac aortic dissection and esophageal reflux, pleural or pleural disease like pleurisy, which causes pain with respiration. Shock, any shocked patient, either low volume or low peripheral resistance, and syncope or pre-syncope, especially postural hypertension or neurocardiogenic shock. Now, whenever you face a patient with myocardial infarction, there is possibility of death, either in short term, immediately within the first hour, or later. For example, there is a 12% chance of death within the first month and 20% within 6 months. So you should assess the prognosis, and this is called risk stratification. The adverse prognostic features of any patient with myocardial infarction are the following. The first is recurrent ischemia. This is a confusing term. By this we mean when you have the severe chest pain of myocardial infarction, which lasts, say, 12 hours maximum. When this pain is over, then the patient might tell you another type of pain, chest pain on exertion. This indicates ischemia. Either another vessel is narrowed or you have ischemic zone which is suffering. you should now try to save this area. The second point, if you have extensive ECG changes at rest or during pain. Third, if you have raised troponin, in contradistinction to unstable angina, we have no raised troponin. Arrhythmia is about bad prognosis, and hemodynamic complication like hypotension, again at bad prognosis. According to that, we have the so-called GRACE score. This is an internationally accepted scoring system called Global Registry of Acute Coronary Event. Depending on history of cardiac arrest at admission, for example, this patient sustained cardiac arrest, you will give him 39 points. The higher the age, the more the points he gain. Dyspnea, I'll tell you later about clip class. Heart failure from 0 to 59. If the pulse is tachycardia, if the blood pressure, systolic blood pressure is low, hypotension is more serious than hypertension, ST segment elevation in comparison to S segment depression, enzyme elevation in comparison to unstable angina, and serum creatinine, which probably indicate poor tissue perfusion. These are the scoring system of acute coronary event. It is very simple. You can apply it to every patient. If you take a photo or scanning or picture of this table from your textbook, it's very easy. You can apply it to every patient. See whether the patient is having heart failure. If no heart failure, give him 0. If class 4, give him 50. And next, see his pulse and later his blood pressure and his age, and then his serum creatinine, whether he has cardiac arrest on admission or not, ST segment elevation, or cardiac biomarkers. And you put marks for each. For example, clip class you give 10, here you give 20 systolic blood pressure, here you give 80, and so on. The total points will be shown in this last table. If he has a total point of 60, then the mortality is 0.2. You will be happy. But if he scores 250, then the mortality is 52. So GRACE score is a clinical tool to stratify the risk of acute coronary event, and you can tell the in-hospital mortality, say 50%, 40%, 20%, etc. Now the last part of the lecture is the complications of acute coronary syndrome. What complications the patient is liable? 3 important: arrhythmias, whether tachy or bradyarrhythmias, ischemia or recurrent angina, or heart failure and hypotension. There are other complications which are important but not so serious. Some of them are serious actually. Mechanical complication, pericarditis, embolism, impaired ventricular function, right ventricular infarction. I will talk about each one in a bit detail, and you can go to your textbook to read more about them. These are important. The first is arrhythmia. The arrhythmias, the common arrhythmias actually are ventricular fibrillation or fibrillation, ventricular tachycardia, accelerated interventricular rhythm, ventricular ectopics, and you might have atrial fibrillation and atrial tachycardia. On the opposite, you might have sinus bradycardia and heart block. Now I will talk about each one. Regarding ventricular ectopic, this is the normal ECG with the P wave and QRS complex. Here you find a white bizarre complex without P wave. If it is infrequent or sporadic, then it does not need treatment. Once it is sustained, then it might need pharmacologic treatment. The best probably will be beta blockers, but there is no use of prophylactic treatment. And some aggravating factors like hypokalemia and hypomagnesemia should be treated. The next is ventricular tachycardia. This is actually a run-off ventricular ectopic. The heart rate is more than 120. If the patient is well tolerating this tachycardia with a white QRS complex, if he's tolerating the rhythm, then drugs like intravenous amiodarone or lidocaine, and you can go and read details of these medications. But if the patient is hypotensive or hemodynamic deterioration, then immediate synchronized direct current cardioversion, something like 250 joules. The third and most serious complication is ventricular fibrillation. It has an incidence of 5 to 10%. It's a major cause of death, and the patient presents usually with sudden collapse. There will be no pulse, no blood pressure. He is cyanosed, and sometimes even he will have convulsion because of cerebral ischemia. The ECG is bizarre, wide QRS complex with no regularity. There is no way to wait immediate and prompt defibrillation within 3 minutes only. Regarding prognosis, the earlier one's better. Anyhow, you should give the direct current shock immediately within 3 minutes. Otherwise, after 3 minutes, there will be cerebral ischemia. And this is the idea why we keep patients in the coronary care units or cardiac care units, to give defibrillation and save his life. Idioventricular rhythm, actually this is a confusing rhythm. It is a ventricular tachycardia with a slow rate, 120. Actually, it indicates a good sign when you have reperfusion, thrombolytic or whatever. Then the ischemic zone probably will be irritated, I should say, and it will give discharge. This is actually not the same as ventricular tachycardia. This is rapid, and this one is slow. And it's self-limiting, it does not need treatment. This is just to, when you remember the differential diagnosis, be careful of these two terms: ventricular tachycardia, whether sustained or non-sustained, and idioventricular rhythm. Atrial fibrillation is common and usually transient. Again, if it is associated with hypotension or circulatory collapse, cardioversion. Otherwise, beta blockers, digoxin, and others will be useful. The same holds true for supraventricular tachycardia. Digoxin if the patient has heart failure, otherwise beta blockers and calcium channel blockers. Again, if hypotensive, you will give DC shock. The opposite, bradycardia. The first is sinus bradycardia. P wave is there, QRS is normal, but this heart rate is slow. This usually does not need treatment, but again, if associated with hypotension, then parasympathomimetic or atropine. The other and last arrhythmia is atrioventricular block, where you have block in this area, and you remember it was first degree, just prolongation of the PR interval, second degree, intermittent drop, and third degree when you have no relation between the atria and ventricle. This is the atrial beat P wave, and this is the QRS. The second P wave is not followed by any QRS complex. The third P wave is intermingled in the QRS complex. That says the atria are beating independent of the ventricle. This is called complete heart block. It can be treated by parasympathomimetic atropine or by pacemaker. The important point here is, if it is associated with inferior myocardial infarction, it is usually temporary, usually resolved by thrombolytic or atropine. But if it is associated with anterior myocardial infarction, third degree or second degree, then this needs pacemaker because it indicates extensive damage. This is all about arrhythmia. The second complication is recurrent angina, and the better term is recurrent ischemia. When the pain of myocardial infarction is over, then the patient might tell you that he have chest pain on exertion. This again, as I told you, indicate that there is an ischemic zone that needs salvaging, or there's another artery involved. In this case, you need a prompt coronary angio with revascularization. Or the patient has dynamic changing ECG. Again, you give potent antiplatelet and arrange for angiography. And the third, if the patient has resistant pain with hemodynamic change. For example, the pain continues, not relieved by opiate, and there are ECG changes. Here you need revascularization with intra-aortic balloon counterpulsation. Never mind about these terms. Just remember, after the severe pain or continuation of the severe pain, or after the severe pain, when the patient develops angina or ECG changes, this is an indication for urgent angiography to save or salvage an ischemic zone. The third complication is heart failure. Whenever you have extensive myocardial damage, obviously the myocardium will not contract properly. And this is staged by CLIP into 4. In stage 1, you have no heart failure, myocardial infarction without heart failure. In stage 2, there is congestion backward in the lung, and you have crackles halfway. In stage 3, severe congestion, all the lungs, severe congestion. In stage 4, there is congestion. At the same time, there is no forward output of the heart. There is hypotension plus crepitation. This is called cardiogenic shock. It has a high rate of mortality, more than 90. So these are the 3 major complications of patient with myocardial infarction: arrhythmias, ischemia, and heart failure. And whenever you follow your patients in the CCU or elsewhere, look for these complications. By history, ask the chest pain or dyspnea. By examination, look for the pulse and blood pressure and features of heart failure and so on. Now we are back to the other complications. Pericarditis can occur in the second or third day. The pain is a bit different, with breathing, with respiration, with movement. Treatment by opiate. There's another type of pericarditis called post-infarction. This is an autoimmune disease that involves both the pleura and pericardium, cause persistent fever, few weeks or even months. Treatment of high-dose aspirin, anti-inflammatory dose, not antiplatelet, or other than steroidal or steroid. Sorry. Mechanical complication. Imagine that you have a fresh infarct. This infarct might undergo tearing or rupture. The papillary muscle which support the chordae that supports the cusp of the myocardium are part of the myocardium. If you have myocardial infarction, then this papillary muscle might be damaged or dysfunction or even rupture. So the patient will have features of acute mitral regurgitation because the cusp is not properly closing, and this leads to acute pulmonary edema. So you might have a patient with myocardial infarction all of a sudden develops pulmonary edema, and when you auscultate, you will find a systolic murmur of the mitral area. Actually, this is an emergency for valve replacement. The second is rupture interventricular septum. Again, hemodynamic disturbance, shunting of blood from right to left, and you will hear a pansystolic murmur on the mid-sternum radiating to the right side. With the right side, cardiac cath is diagnostic with echo, and treatment again is surgery, but this case usually fatal. The other fatal entity is rupture of the ventricle itself. So mechanical complication might present with pulmonary edema and systolic murmur, or hemodynamic disturbance and pansystolic murmur, or sudden death. The other entity, this is called impaired ventricular function, not yet in heart failure. This is something called infarct expansion. This is a thin infarcted area. The area will expand. The other part of the ventricle will hypertrophy. This is called remodeling. So you have a thin stress segment and you have a hypertrophied segment. Obviously, these will not be synchronized. There will be no synchronized contraction, and this might end in heart failure. Actually, the drug angiotensin can prevent this remodeling. So one of the indications of AC inhibitor is extensive myocardial infarction before heart failure and heart failure itself. The last 2 or 3 complications, left ventricular aneurysm, 10%, when there is persistent occlusion of the vessel. It will cause arrhythmias, heart failure, mural thrombus, etc. And actually treatment is difficult, usually diagnosed by echo, and it needs surgical removal. The other complication, extension of the infarction from left ventricle to the right, involvement of the right ventricle. What we talked about in the lecture was left ventricular infarction. Sometimes inferior myocardial infarction of the left ventricle, the inferior wall, is associated, 1/3 of them, with right ventricular infarction. This extension of the infarct to the right ventricle, clinically the patient will have features of right ventricular failure, raised JVP, small sign, hepatomegaly with or without hypotension. ECG, this is important for all of you, especially 6-year students. When you, inshallah, become a 6-year student, a patient with inferior myocardial infarction, always you should do a right-sided ECG, especially in lead V4 right side, to exclude, especially first 24 hours, to exclude extension of the infarct to the right side. And the echo again will show right ventricular dysfunction, and catheter will be diagnostic. Why? Because if this patient develops hypotension, a patient with inferior MI that develops hypotension, and you know there are many causes of hypotension in MI, if it is due to right ventricular infarction, then the treatment will be IV fluid. Hypotension is very serious finding in myocardial infarction, but in inferior infarction, it might be due to right ventricular infarction, and in this case, you give IV fluid. The last complication is embolism, whether arterial because you have a fresh infarcted surface, systemic embolization. A patient, imagine with myocardial infarction, develops a CVA or limb ischemia, and the venous side due to stasis. This is all about the complications of myocardial infarction. By this time, I come to the end of my part 1 of my lecture. Next time, inshallah, I will give you the second part of my lecture, and that's about investigations and management. And if you have any question, you can send the question. Thank you very much. See you again, inshallah.